the prison systems. There's a large populations of people that are in prison systems that are being cared with I don't know what. But at least they're in a sense captive to assure that you can, monitor the medications. So there's that. And there's also sort of on the other end, sort of the going in part, and I think Arun really highlighted the need for early intervention. There's kind of continuing care and compliance, which really needs to happen. And there's this crazy catch-22 system where as soon as my son came to be of age, he was now responsible for making his own decisions. Now, this is a person who does not have insight. He has anastomnia, which is a common trait in this illness. And you're asking him to say what's good for him. And he doesn't think he has an illness. He believes rabbits can come back to life and he can bring back his dead girlfriend's father, but he doesn't think he's sick. And he's the one judging whether or not he needs to take medication or not. And it's bananas on the front of it. And so there's some thoughts, and I guess the last thing I would mention is on the back end, as people come out of care, there is a terrible lack of anything that I would call kind of humane supervised housing. There is a need for people to kind of move into housing and so they don't wind up in the streets. I mean, the alternative is often if your family won't take you back in, which they often have good reasons for not wanting to have happen, then you're going to go to a homeless shelter. And that's probably like the most challenging environment any person can be in. No job, no place to go. You're kicked out the door by the mid-morning because nobody stayed in the homeless shelter, and you're supposed to make ends meet, and you're sick. So it's just very inhumane, and there's just across the chain, there's so much need for work here. But I would certainly start with improved medication, medication alternatives, ones that can be readily administered and hopefully aren't crazily costly, which hopefully the insurance companies can do something with. And I really truly believe, I look at the bills that we were getting and what was kind of being reimbursed and what the nominal costs are that the hospitals are putting out. I cannot believe that Medicaid, Medicare are standing for this. They should be driving these costs way lower by insisting on certain changes to the way medication is administered and developed in this country, because it's madness. My thought.
All right, no, a lot there. That's great. Let me invite the clinical experts. Vinod, the STEP program that you work with, I mean, other experiences you've had, what do you think needs to happen for us to try to get better equity, if you will, better health equity out of the way we treat patients who are living with schizophrenia?
Yeah, I mean, this is a very broad question. I think that part of the tragedy is that if we just did what we already know works, we would see substantial improvements in the quality of life and the management of individuals, of which intervening, not even just early, but just not terribly late. I think the standard delay between psychosis onset and treatment is measured in years in the US. So we're not really even talking about early intervention at this point. I'll say that a couple of studies that have looked at medications that are already available on the market that are delivered at reasonable doses, according to current guidelines, in a manner that patients are able to tolerate, routinely deliver remission rates north of 80% at 1 year. So what that means is that the current medications in reasonably skilled hands could give people almost complete symptomatic relief early in the course of the illness. And so in some ways but that's not, of course, what happens in most healthcare systems. So we're talking about delivering a novel medication and hoping that its effects, even if they are small, might be in advance, and they certainly might be. But the reality is it occurs in a context in which much of this care is poorly resourced. There's a lot of demoralization in the workforce. Prescribers are often prescribing several medications that go contrary to the evidence. So we have a sort of healthcare environment that's under-resourced, generally good care to such a degree that even an advance in treatment might get washed out by the general chaos. So I'd say the good news is that there isn't any nihilism is not justified. People can actually benefit a lot from the current treatments. And in a context where the workforce is supported in considering different options and delivering them carefully at the right doses, a new medication could be an excellent tool. We need as many choices as we can possibly have. But I'd say I know amongst health economists, there's a story here that can entirely be told around incentives. And I think if you're a commercial payer and a young person becomes ill, they usually fall off commercial insurance if they don't get adequate care because they drop out of college or leave their parents' home or lose their employment and end up on Medicaid. So we have a bit of a perverse incentive there to not enrich care early. And I think the benefits of early and just good treatment in the course of the illness land on so many different budgets that you know, the effectiveness of good treatment by a hospital might mean less hospital days and less jail days, but those effects are diffused across so many different budgets, and it's hard to get stakeholders together to invest in this population. So I think, yeah, I thought we were going to be talking really about a new medication, but I think the context here is it could be really helpful if we sort out just ordinary good delivery of care we already know how to do. It would be much more powerful on a system like that.
Yeah, sadly, that's not very uncommon in our conversations around what needs to happen next. Steve, I want to give you a chance to chime in too if you have any thoughts.
Yeah, I'd like to dovetail with Dr. Sahari's comments. So I think all of us would agree, and this is maybe not the right comment to make at a pharmacotherapy meeting, but I think all of us would agree that medications alone are not enough. I would argue since 1953, there have only been 2 breakthroughs in the pharmacotherapy of schizophrenia. First was discovery of chlorpromazine. Second was discovery of clozapine, first of the second generation. During the same period of time, there have been multiple evidence-based treatments that have been proven to work in different ways through multiple randomized control trials. Things like integrated dual diagnosis treatment, since half of people with schizophrenia have co-occurring disorders, assertive community treatment, forensic assertive community treatment, individual placement and support. It was said earlier that most people with schizophrenia are unemployed, but they want to work. There's an evidence-based practice for getting them back to work. Family psychoeducation, probably second only to pharmacotherapy and relapse prevention efficacy when you have patients living at home. These treatments exist and they're not being supported or used. So that to me is a problem, and it's an opportunity to get better outcomes for people with schizophrenia and their families. The other point I would make, this point has been made earlier, that if you have a severe mental illness and you don't know you're ill and you're psychotic in the wrong place at the wrong time, you end up in the criminal justice system. That is a problem, but it's potentially an opportunity. If we can get mental health and criminal justice professionals to play together in models like forensic assertive community treatment, where there's an emphasis on problem solving and therapeutic alternatives to punishment, then it can be the beginning of the road to recovery for many people. So I'm rambling, I'll just leave it at that.
No, you're not rambling at all. But I do have, I guess, a difficult question, which is, none of this is very new, right? At least since deinstitutionalization, we've had problems with homeless and schizophrenia. And when I was a medical student many years ago, we were so frustrated because we would have a patient inpatient for 30 days and get them started on a long-acting depot treatment, and then we would have to send them back out onto the street. And there was, you know, you could try to get a social worker involved, but they had no place to go at that point, and family was, we couldn't even figure out who the family was. It was just a disaster. It was an utter, you know, structural disaster, because all they were going to do was not come back for their next depot injection and then end up with another schizophrenic break at some point. So there must be task forces right now, you know, the White House or somebody's been having task forces on this probably forever. But like, seriously, if we had to kick somebody into action, what would really need to change? Do we need to build more mental hospitals? Do we need to have a whole different branch of CMS talk about what's that halfway between inpatient treatment and an outpatient treatment? What is the bridge, and who funds that, and how do we do it differently? So you guys have painted a very dire picture, but across a very broad tableau. And I'm wondering, are there any places we can really say this would, make a huge difference if we could just do this one or two things? Vinod?
Well, I was going to say that if it sounded dire, that wasn't my intention. I think Dr. Lamberti said it better than I could. We actually have an embarrassment of riches when it comes to treatments that do work. We just don't implement them. And I would add that the kinds of patients that come to mind when people think of these illnesses reflect largely the clinician's illusion. These are individuals who often have had the worst access to care, have sort of dire adverse social determinants. And while they deserve our care, and in fact, much better care, they are not representative of most individuals with these illnesses. So experts like us tend to accumulate cases that don't respond to treatment, which is exactly how it should be. But we're very bad at prognosticating. In fact, most individuals with these illnesses live lives of variable amounts of recovery in the community and are often not advertising that for obvious reasons of stigma. So I just want to level set a bit here and say that the kinds of cases we think about that we fail routinely in our acute systems of care, we should do better, but they are not in the main what the prognosis of these illnesses are. And we're talking about people who are making a contribution to society and are tax-paying individuals in colleges and schools and professions. So I just want to be clear that when I speak about in somewhat dire language, I'm impugning the healthcare system, not the individuals with the illness. And I think there's a lot that we can improve with existing treatments that would make a dramatic difference without even a new novel treatment. But secondly, I'm very excited for novel treatments. I just worry that in the absence of sorting out our house in terms of access and just good psychosocial treatment, even a pharmacologic advance will not have the opportunity to show its extra value because it will get washed out with, people who just can't have access. They don't show up. They aren't encouraged to stay on the medicine in the face of adverse events, which all takes time and trained staff to implement. And I worry that we will lose this opportunity to implement yet another treatment that does have some effectiveness.
All right. Actually,
I don't have an answer, Stephen. I'm hoping you do on how to fix it all.
I'm just going to pitch you a few ideas. So, and then Arun, I'm coming to you. So when we've dealt with issues before where we felt or we heard that there was a problem with knowledge among practicing clinicians about how to take care of more complex patients, the solutions end up being some variation on telehealth so that doctors in the community can quickly access an expert who can help advise them on care, and that the insurance structures and provider structures are there to facilitate that kind of activity. And or some kind of basic outreach from clinical specialty societies to do more education. Around the opioid crisis, there was a huge effort by actually the federal government and state governments to reach out to educate, to require education of primary care doctors in issues related to opioids. So I'm just are those two options? Does anything really jump out at you as ideal between telehealth, better education of docs, or something else?
Yeah, I like something we're doing in Connecticut, and not just us, is using an idea that the Institute of Medicine came up with in the early 2000s of building learning healthcare systems that explicitly address application of the science we already know, but also recruitment for trials, much like the standard in pediatric cancer is the places that provide the best care are also actively recruiting for clinical studies. So there isn't this gap between clinical excellence and research. So science, but also working on incentives that include payment systems, obviously, on cultures of practice that are able to support both of these, support measurement and feedback. And I think finally informatics, which are really broken. We have very little feedback provided to clinical teams about whether their efforts result in improved outcomes. I suspect they do, but our current informatics systems are really glorified coding, billing, cash registers that do not give clinicians a sense of whether what they're doing is resulting in reduced homelessness, better housing, better, reduced hospitalization. So I think that's, if you ask me for what I would fund regional learning health systems that can implement population health across entire, states, for example. And that might actually allow us to do this, implement what we know, but also recruit for studies to perhaps do phase 4 post-marketing trials for something like KarXT in real world, representative samples. So if you give me $10 million, that's what I would do in Connecticut.
Oh, you're asking for way too little. We're going to give you a magical bank account to ask for a lot more than that. So keep thinking big. Arun?
I just want to chime in on the educating providers. If you're thinking of like a place to intervene, we hear so regularly from our community about how they're just unable to find a provider who specializes in schizophrenia. I think in addition to what Vinod said, there's a need, I think, to like understand, to kind of go even earlier in the pipeline. Like a lot of people opt out of psychiatry in med school. A lot of people choose not to kind of pursue schizophrenia within psychiatry. There are kind of reimbursement differences in how much they get paid for this sort of work. There's also research showing that they're kind of in some aspects of stigma are comparably high in providers who work with schizophrenia than as high as they are in the general population. There's so much that we need to understand in terms of like the training standards and kind of like residency training and such, that I think if we go even earlier in the pipeline to focus on schizophrenia and bring in these kind of treatments that would work. Just to kind of drive home this point, my understanding of the American Psychiatric Association's guidelines for like when to prescribe clozapine is after 2 6-week-long trials of oral antipsychotics that don't work. It doesn't happen. Like people are not following kind of like standards of care. And I think this is just, there are so many things we need to do to kind of train providers better. I also think given that so many people with schizophrenia, end up switching medications or starting medications when they're in an involuntary hospitalization, there needs to be kind of like addressing an elimination of certain policies that interfere with this continuum of care. So one of those is like the IMD exclusion, which our organization thinks discriminates against people with schizophrenia by limiting the number of hospital beds. So even something like increasing like hospital bed capacity, lengths of stay, and stuff like that to stabilize people on medication could potentially be effective.
Okay. Yeah, that was a great conversation, and we covered a huge amount of territory. And I also want to signal that at the end of this policy roundtable, I'm going to come back around and invite each of you to have a final statement, and which part of that is an invitation again to list your top ask of some specific decision maker or power structure or whatever it might be of what you think they could do to make the world a better place in the future for people living with schizophrenia. So keep thinking big, but also thinking specifically about whom you would tap on the shoulder to say, please do this. All right, so we'll come back to that. I want to now move, we're about an hour out. So let's talk about some of the aspects around KarXT in particular as it comes in as a drug into a world in which there are formularies, there are price negotiations with the manufacturer, there are things like step therapy sometimes. We're just going to kind of explore that as an aspect of the access and the other aspects of what we want to try to get right. So I want to start just a little bit with, again, and this came up in some of the questions from the CEPAC Council, how this drug will be used in practice. Let's go to the clinical experts, because we just want to hear from your thinking. I mean, there might be a best practice, but just generally, will this drug be used first? Will doctors want to use it first? Will they want to use it in an acute exacerbation? Will they want to switch patients off of other drugs that they've been stable on in some ways, except for the side effects of weight gain? Will they want to switch patients off of that kind of treatment regimen? What's your idea of where this drug fits in the armamentarium? Steve, let me start with you first this time, perhaps. Because I want you to advise, because you're speaking not only to your clinical brethren, but imagine you're also speaking to a room full of insurance companies, and they're going to be creating yes, no's around coverage. And so tell them what you want them to know about how this drug is going to be used appropriately.
Yeah, that's so hard to do because we just only have 5-week data. And the data suggests that there might be less risk for weight gain and metabolic side effects, but possibly more risk for discontinuation. And I sort of feel like that's all we know. So my guess, just based on clinical experience, is that when it's approved by the FDA, it will get used. Some clinicians are early adopters and they'll use it first line, but most clinicians are cautious. And so they'll tend to use it for patients that have somewhat of an indication, which would be perhaps real bad metabolic side effects, or maybe even non-response, but they're not ready to take that clozapine step, which probably should be taken first. There will be other clinicians that will perhaps use it as an adjunctive treatment. So I think it's going to be a little bit all over the board. That's my best guess, but I would also defer to my colleagues here.
Before I let you off the hook, I want to ask about that adjunctive therapy.
Yeah.
Because that often comes up within kind of insurance decisions about how they write their coverage. Can it be used at the same time as another antipsychotic treatment? Because it's obviously never been done in a trial where you use two together. So from a clinical perspective, though, is that going to be an important use case for this, where I don't want to take them off the treatment, but I do want to add on this new one, KarXT?
Yeah. So one of the principles of combined therapy, or polypharmacy, if you prefer, is when you're using two antipsychotic drugs together, you try to get drugs with different mechanisms of action. Does it make sense to use two high potency dopamine blockers? So this has a different mechanism of action. So I think there will be temptation when somebody's not responding well to medication A, and if there's a contraindication to clozapine, then you'll want to use an adjunctive agent. I could see this agent being used. The cautionary note will be that it really hits the cholinergic system both ways, and many current antipsychotic drugs are quite anticholinergic. So we would certainly want to be cautious about potential problems with GI motility, et cetera. But I think because it has a different mechanism of action, there will be temptation to use it adjunctively.
Okay, thanks. Vinod, please weigh in. Same question. You're in front of a room full of other people who are going to tell doctors what they can and can't do, at least with insurance coverage. What do you want them to know about how this drug is going to be used or should be used in practice?
Well, ideally, when we're faced with an individual who cannot tolerate the current standard treatments which I indicated work well for most, they would be enrolled in a trial that would compare them to different options. Drug A didn't work, then does KarXT work better than drug B? Alternatively, if drug A worked a little bit, but there's still residual symptoms, does adding on KarXT improve things or make things worse in terms of tolerability? So I think for me, they're just questions about its place in treatment. But I think if you ask me how will it actually be used in practice, I suspect, like Stephen mentioned, tolerability is the big driver of whether or not individuals will take antipsychotics, because most of them work. If they block D2 receptors between 60 and 80%, they will work for positive symptoms. The challenge is getting people up to that dose, and often it's determined by tolerability. And so this could end up being used if, in fact, prescribers discover that they can get individuals to tolerate adequate doses. And that's a question mark because there are a lot of gastrointestinal side effects, and with inexperienced prescribers, they may be more likely to switch off this medicine very quickly if patients complain. So it's hard to predict how it would go, but I think there'd be an appetite to try it just because many individual patients do not tolerate the first antipsychotic they're trialed on because of other side effects. So, yeah.
Okay. So first, let me paint the stereotypical picture in which we've got very inexpensive generic treatments, and we've got a new one coming in, and it's promising in terms of lower side effect profile. It's not like it's a home run in terms of better clinical effectiveness in terms of its effects on, psychiatric symptoms, but the side effect profile looks better. Aren't there going to be a lot of doctors, primary care even, who are going to want to start with this drug, even though it's a lot more expensive than the generics out there? And I'll come to the payers, and the question for you is, aren't there going to be a lot of payers who want to stick with the tried and true, less expensive existing treatments and see if those work or don't work first before allowing coverage for a much more expensive option? So let's just deal with that tension head on. But my guess is that there are going to be a lot of docs who are going to want to start patients on this first.
Yeah, and I think I hear two questions. One is, should payers restrict formularies? And my general response as a clinician is no, because choice is really helpful to have with individuals who might, for idiosyncratic reasons, prefer one drug over another, or truly have side effects that make one less or more preferable than the other. So I'm not in favor of restrictions in that sense, although I understand that it may be necessary in some settings. But what would we ideally want them to do? And I think I'm with Dr. Lamberti on this. I guess it's for an illness for which we expect people to be on this medicine for presumably their lifetime or for at least several years. It's hard to extrapolate effects from short-term studies and recommend that it be used first. So I probably would be not an early adopter and would discourage people from using it first. If there are treatments at hand that are working quite well and have people in remission.
Okay. We're going to come over this question from several different angles. Let me move first to the payers. Thank you for holding tight. Kristen, don't worry. I'm coming back to you. Don't worry. But let's talk to the two payers. We've got Tony and Marina. I'm not seeing Marina on my screen, unfortunately, but I know she's probably still here. Okay, guys. So again, completely stereotypical, and feel free to push back. But this is not that unusual a situation in which we do have clinical guidelines saying that, appropriate first-line therapy is these drugs, and they're very inexpensive. Annual price, $50 to $100, in that neighborhood. Now you've got a new treatment that some clinicians will view as preferable. Some patients and families might view as preferable because of the side effect profile. And it costs thousands of dollars, right? 10, 20. And on the other hand, according to our at least model, giving it credit for long-term metabolic syndrome without having that risk, it would even be fairly priced from a cost effectiveness perspective between about $16,000 and $20,000. So you don't have to speak about what your organization is going to do, Tony, but Marina, you might talk more broadly about what payers do in different walks of life. What do you expect is going to happen to this drug if that's the stereotypical story in which, if that were to happen, a lot of payers are going to put that drug behind a step therapy protocol in which they have to try the other treatments first, or in some other way encourage patients not to try that as their first treatment. Marina, let me start with you perhaps. Do you expect a fair number of payers to do it that way? What are you thinking or hearing?
Sure. So as we all know, this is a heavily genericized landscape, and IPD expects that if KarXT is approved, payers will manage the agent similar to other branded antipsychotics. So there'll be a verification of indication, so schizophrenia, and a step through one or more generic second generation antipsychotics. And I will say that IPD did a recent survey specific to KarXT for payers and psychiatrists. And it seems that at this time, with the current data available, that they're viewing KarXT as a second or a third line therapy and are anticipating reserving the agent mainly for those patients with schizophrenia who have experienced intolerable adverse effects on first or second generation antipsychotics, or who have significant negative or cognitive symptoms. And I think that as we see some of the longer term data come in, maybe that will impact how payers and psychiatrists are viewing the agent in the treatment continuum. But I do expect that KarXT will be managed with step therapy, and the number of steps through a generic second generation antipsychotic will likely be what varies payer by payer.
All right, thank you. Thank you. So, Tony, let me ask you again, just from your general experience, or if you want to talk about anything specific about this drug and what you guys are starting to think or what you've done with prior branded antipsychotics, feel free to. But isn't this kind of almost a stereotypical story in which the usual answer is to put it behind a step in which patients have to try other treatments first or do something else to slow down or narrow the population that will take it?
So, Steve, I would say that it does sound like the stereotypical situation, but not in the stereotypical indication or kind of context. So overall, there's plenty of other examples where everything in the category goes generic, and then a year later, a brand comes out and it's like, we just decreased costs in this category. And it's very frustrating from a payer in that perspective, and they want to leverage that savings. What I would say is in this particular category, well, outside, let me separate from Medicaid, because a lot of that, the Medicaid situation is run by the state. Not a lot of autonomy around some of the payers that someone like Express Scripts represent. And also, let me say that this, I don't speak for Express Scripts. We have an independent P&T that makes decisions around coverage and clinical criteria, and that has not been done. That said, there is not a lot of PA steps in this category today for a lot of commercial payers. And a lot of that has to do with the fact that a lot of this patient population and things like adherence, when you put those steps in front of them and there is disruption or walkaways, there's a big effect around decompensation, and then out of control medical costs that you see right after that, right? Around, going to emergency rooms, hospitals, that kind of thing. So what I would say is overall, from a commercial perspective, I understand the unfortunate journey from commercial over kind of to get Medicaid in the state, but during that time, especially in the commercial, on the commercial benefit, payers are very supportive of making sure that there is access and coverage for these therapies, even when the atypicals were brands, even when, in that situation, because having a patient controlled on therapy is a lot less expensive, a lot better control than stopping something, decompensating, and then one, the cost of hospitalization, and two, that patient never gets that back, right? Like, that decompensation. So I would say, by and large, for a lot of commercial payers, I don't really expect to see a lot of step throughs, at least in a lot of the clients that I work with, the payers that I work with. I could see some situations around PAs to indication, to label and that kind of thing. But overall, I think that payers look at it as a welcome novel mechanism, another tool in the toolbox. And I think the feeling is that a lot of providers are going to go with the standards because they work. The point, we talked about today, that they'll manage in a certain kind of stepwise approach.
Well, I think that's where the friction will come. I mean, a clinician who has, if you will, equal access to all of the different options might still pick A before B before C. But at least when I had our team go and look for kind of available insurance policies available in the public domain, and they pretty much all had steps through generic antipsychotics to get to a branded drug. So I'm hearing what you're saying. But I also wonder if Arun or others, if you have your own experience with any data on this or any knowledge about what kind of what relative barriers there seem to be to getting branded antipsychotics. Oops, maybe we might have lost Arun. Oh, there you are. Arun, do you know anything about that?
About barriers to getting branded antipsychotics.
Yeah, well, we're talking about step therapy basically. And again, step therapy doesn't necessarily kill people, but it's one of the major complaints that people have about their insurance coverage, and clinicians don't like it. So I'm just curious, if we're talking about the possibility of step therapy for KarXT, what's your general knowledge of the extent to which it's in play currently for people trying to seek a branded antipsychotic?
What I do know about this is generally that doctors, there again, like that there's like kind of a lack of training on these kinds of like the sorts of therapies people should try first. Prior authorization is kind of like the bane of our existence in terms of accessing care, and that our organization really believes that the kind of decision on medication should be a shared decision between doctors and patients, and we kind of stand against anything that gets in the way of that. Thank you.
Okay. So again,
Yes, I can comment on that if you wish.
Yes, please do. Before you do, I just wanted to make a
Yeah.
brief comment that I hope people understand that part of my job is to ask questions that may make people feel a little bit uncomfortable. I'm not trying again to make people feel like there's a gotcha question, but I hope you will all, and I think you do, understand that we're trying to probe some pretty important and sometimes contentious issues. So thank you for bearing with me if my questions seem to push you a little bit. Please, Vinod, go ahead.
So I treat a population that is about 50% Medicaid, and then the rest have varieties of commercial insurance in Connecticut. And I guess Dr. Lamberti might be able to help me understand if this is generalizable, but prior authorization for branded medications is usually not a problem if they are standard oral medications. It tends to be a challenge with long-acting injectables. And I think once prescribers go down those rabbit holes, it tends to be a very arbitrary, prolonged process that varies between different payers in ways that don't make sense in relation to the evidence. So some payers cover one versus not the other. It's not clear why. And that's the sense in our center too. But when it comes to PO, like by mouth, in general, this has not been a problem with the second generation antipsychotics.
Okay. Steve, is that your experience too?
Yeah, pretty much. There's a lot of variability by payer. Some requesting prior auths and some not so much. In New York State, Medicaid has been probably one of the most supportive funding sources in terms of prescriber choice. But now we're starting to see Medicaid managed care plans. And so it does vary a lot.
Okay, great. I'm going to come back to the payers later about some other things, but Kristen, I think I do want to bring you into the conversation, and thank you for being so patient, toying this long. So you do not have an FDA approved drug, so I know there's a lot of things that you can't comment on. You do not have an announced price. I understand all of that. So let's just talk about how the world works or could work. So, as I heard certainly the discussion, and actually David Wren, ICER's chief medical officer, as a primary care doctor, said from his perspective as a practicing doc still, he would view an important part of the value here to start this drug as early as possible to get the long-term benefit of avoiding weight gain and metabolic syndrome, instead of maybe seeing if the patient does gain weight and then trying to, help them lose weight afterwards and switch them off of it or something like that. On the other hand, there's a usual kind of inertia when a new drug like this, especially one that's more expensive, enters, and clinicians may want to start with the other drugs available, or some insurers will want to put step therapy and start with those other drugs first. My understanding is that when companies get into the negotiating room with payers, sometimes they will say, we'll give you a lower price if you will not put any kind of blocks in front of using this drug first for patients and doctors if they want to use it first. Do you think that is going to be part of what's going to play out here for this drug? Do you agree that getting this drug used first might maximize its clinical value? And if so, is there a role in which a lower price could play in helping patients get access to it that way? Did I ask a huge multi-part?
That's pretty loaded.
Way too many questions there, but what do you think?
I guess just to level set that we're anticipating that KarXT will be indicated for the treatment of adults with established diagnosis of schizophrenia and monotherapy if it is approved. I also want to point out that the evidence report that ICER produced places us as a viable first-line treatment option, and we agree that it could be clinically appropriate in the first-line setting and potentially offers improved tolerability to current standard of care in certain patients. We also want to point out that treatment for schizophrenia is highly individualized, so KarXT could offer benefit beyond a first-line treatment option if patients aren't sufficiently responding or unable to tolerate traditional therapies. So similar to what was said earlier, it's, we anticipate it may be a mixed bag of how it's used in clinical practice. With respect to any kind of, pricing and contracting type of discussions, I'm not really able to speak in detail about that, but I can say that we're committed to engaging with payers that provide coverage for people living with schizophrenia and delivering the evidence they need. And we're kind of open to all contracting possibilities.
You did a very good job with my inappropriately specific question. But that doesn't mean I'm not going to try again later. So, and one way I'll try again later is to now turn to the payers and say, okay, I painted this stereotypical picture. And we have heard in ICER public meetings before, payers say, hey, look, it's not whether we're going to cover it or not, but honestly, if the price is way up here, the prior authorization will look more challenging. And if the price is down here, the prior authorization will not be so challenging. That is the way that the world is going to work. Tony or Marina, again, do you guys think, again, given this kind of prototype or stereotypical situation, if there will be discussion about this drug being used first for some patients at least, do you think a price negotiation in terms of that part of the prior auth is going to be on the table? Marina, let me start with you again from a general perspective, or do you think that people are just, nope, it's so much more, even if the price comes quote unquote way down in the thousands, it's still going to be so much more than a generic that it's going to be stepped yes or no based on that. It's not going to matter if I get another couple extra $1,000 off the price. What do you think?
Well, I think it depends on the payer. It depends on the rebate negotiations. It depends on kind of all of those discussions. And I do think with the disparity in cost between a generic second generation antipsychotic and then what we anticipate the price will be, the list price for KarXT, I think it would be a difficult negotiation to get a payer to say, well, we'll just place it as a preferred brand with no step. That being said, I could see that as being part of the discussion. However, with the current data available being limited to, the 5-week data, patients that were inpatient, we haven't seen the emergent 4 and emergent 5 data yet. I think that might be a trickier discussion. So.
Yeah. Tony, what's your general gestalt here? What, if you're thinking about the ultimate negotiation that will happen between coverage and pricing on this, how do you think the elements will be weighed against each other?
Yeah, I think there certainly will be value and access conversations, and payers will be looking to try to decrease their costs as much as they can. I think this is a good opportunity for an outcomes-based types of arrangements and looking at costs. And I think those conversations, if they haven't been had, should be had. But overall, I mean, again, and I can only speak to from my company, Express Scripts and how we have historically managed the utilization management and formulary associated with these products. I'm sure there's variability in the marketplace, but very, very tight is not something that has been pervasive in this category for us.
Right.
So, that starting with this one drug seems a bit unlikely. That said, we have our own P&T, we'll look at the clinical data associated with the product. But, I think that, PA to label and focusing on the data that is in the clinical trials is reasonable, and that will be looked at. And then as far as access and contracting after that, you go from there. But I do think this is an opportunity for us to look at outcomes or value-based type of arrangements to help incentivize care, right? And overall net cost versus just looking at one benefit or the other, or one stakeholder or another.
Okay, I'll come back to that, because honestly, I don't think it stood out to our team as an ideal situation for an outcomes-based contract. But let me, I guess I can come back to that. Now I need to ask what will be viewed as an unfair question in certain quadrants. So I think I will ask it of Marina as a general question. Some people have complained in previous examples of new drug introductions that in order to get pharmacy benefit managers to prefer a drug, the list price had to be quite high so that there would be a very large rebate in order to compete, especially with generics. That the only way that they could do that would be to create a very large rebate stream. And there have been isolated case examples, at least, in which some people have claimed that some insurers have even favored more expensive drugs with big rebates than generics because they can't make as much money off the generic. Is this that kind of situation where there will be considerations around the size of the rebate and whether that plays into the relative positioning on a formulary relative to the very low cost generics?
Sure. So thank you for that question. What I'll say is, rebate, the level of the rebate is always going to be a consideration when it comes to formulary placement. In my opinion, I don't think that this is an example of, with the price needs to be high, so the rebate's high, and then that will equate to favorable formulary placement. I feel like payers are going to review the data, look at the significant unmet need in this population, look to the fact that we haven't had a novel drug approval in this disease state in decades. And I think that's going to be part of the consideration for formulary placement. And I think just the discussion around STEP and, preferred brand versus non-preferred brand, it all just equates to, what does your patient population look like? And, looking at the data, do we feel like it's reasonable to, have a patient try and fail at least one established antipsychotic therapy? And I think, and we'll probably talk about this more later, but I think, there are a lot of research gaps that I think we would all love to see addressed. But to go back to your original question, I don't think that this is a case where, a high price and a big rebate would necessarily, like, people are waiting for that for preferred formulary placement. I think everyone's excited about the potential for a novel treatment option in a patient population that sorely needs a new and novel treatment option. But we kind of have to look at the treatment landscape as a whole.
Okay, thanks. I want to come to outcomes-based contracts in just one second, because as I said, we hadn't really thought too much about that. But Tony, back to you around, so I've talked about step therapy a bit, because that's usually a big issue. Another question will be, what tier will this be on in terms of out-of-pocket requirements for patients and their families? So again, you've got very inexpensive generics. This is going to be a specialty drug. And at least in some employers' benefit designs, that would mean that patients would have to pay 20% or more, even after their deductible. Are you thinking about this kind of situation any differently because of the issues around adherence and the idea that we really want patients prescribed these medications to stay on them. What do you think the role of tiering is going to be here?
Yeah, I mean, typically most payers don't differentiate tiering in the specialty space, right? So they have a specialty copay, and typically if there is a percentage, there's a max. So I don't think that's a situation that there's going to be a deviation from the norm. I think what you probably will find in the situation, not knowing what it really is, that they will follow that same benefit structure, and that the manufacturer will have a copay program and systems to essentially to work within that same paradigm that most other specialty products are work within.
Yeah, I agree. If we go back to that very first question I asked around how could the whole system work to introduce a new drug like KarXT and help with health inequity, one way would be to acknowledge the challenge of the fact that this is going to be, on paper at least, probably more out of pocket unless there's a large, copay coupon from the manufacturer, which might drive up inequity. It would allow, wealthier patients and families to afford it, whereas others would not be able to and would prefer the cheaper generic medication. Not that again, is the end of the world, but Kristen, do you guys, you probably can't talk at all about patient copay assistance kind of issues, but do you have any general comments on that question about the out-of-pocket and your hopes for what could go right with that?
I mean, all I can say is that we'll work to optimize patient access through any kind of patient support programs we can implement, that we're able to do. So.
All right, because I don't think it would be averse, at least for us in our policy recommendations, to recommend that payers think very carefully about the impact of the out-of-pocket requirements on adherence in this case, because it's bad if a patient doesn't take almost any prescribed medication. But in this case, adherence is such an important issue and so challenging to begin with, and equity is such a problem to begin with, that it seems a shame if a new drug is disfavored primarily because of the out-of-pocket factor. Arun, I don't know if you guys talk about this within your groups, or Mark, if you guys would like. Oh, Mark, please.
Yeah, just I wonder, maybe a long stretch, but I wonder, instead of kind of working through the private, payers taking leadership here, if it could be convincing. And Medicaid is handling an awful lot of the schizophrenia cases, and they've got a huge basket of people who are under their sort of, they're paying for, and they're paying a lot. So I guess the argument would be, try to be long-term greedy, not short-term greedy, and, spend some money on an experimental basis, almost sort of randomly, and then see if positive results come out of that. And I don't know who makes that case, if it's the manufacturer or someone else, but from a policy standpoint, I think it would be a very sensible way, to get a widespread trial across the country, different backgrounds and what have you, and see if it works, see if it makes a difference.
And you mean make a difference in just in terms of health outcomes, or do you mean in economic outcomes for people?
I think they're related. I would argue that they're quite closely related. If you could get people to be stabilized and not, experiencing psychosis and schizophrenia, it would save the government a ton of money, and not just the government. I think we've sort of alluded to, local police forces and hospitals, emergency rooms and jails and what have you. There's a big societal burden that could be kind of addressed.
Yeah, one of the things that modeling can do, but it's really hard to do. I mean, when the model was presented, you may remember Mel had a criminal justice component of productivity at work. Those are always challenging if there's not, primary data. But it's also always challenging to try to figure out, let's say that a new drug really made a difference and a lot more people living with schizophrenia on this treatment were able to have gainful employment and get insurance and move off of Medicaid. That makes it an even better economic deal for a state, if you will. In addition to obviously the health benefits, it's beneficial for them if they don't have to pay for another Medicaid patient. So anyway, that aspect of this, I think, is worth at least acknowledging in some way. Arun, I don't know if you wanted to talk at all about the out-of-pocket factors, or if you feel like Mark and others have handled it.
I think Mark and others have mostly handled it. I just want to highlight again that caregivers have so many out-of-pocket costs that they're already paying for. relating to like substance use treatment, which often isn't covered, arrests, psychiatric hospitalizations, care expenses, to kind of like layer on to that just seems like such a huge barrier to access that I think is critical to address.
Great. Sorry, we had a tiny bit of background noise, but I think somebody caught it and went on mute. Okay, let me ask quickly then about the outcomes-based contract. Kristen, I guess let me start with you. You've probably thought about this a little bit, but as I envision it, one of the primary benefits, sorry, we're getting some background from somewhere, but one of the primary benefits would be a patient has, let's say, equivalent kind of psychiatric outcomes in terms of hospitalizations for schizophrenia, let's say. The real distinctive benefit is the reduction in weight gain that could be expected with the other treatments. How do you frame that as and I'll come back to you, Tony, too, maybe you've already had specific ideas, but how do you frame that as an outcomes-based agreement? What would have to happen or not happen to trigger an additional rebate or something? Do you have any ideas, Kristen?
I mean, like I said before, we are following developments in innovative payment models, and we're open to all contracting possibilities. I do want to point out that the largest cost drivers in this area is related to hospitalization and relapse. So, that's something that will kind of account for the holistic picture of care when you're considering, kind of back to the previous point about out-of-pocket costs, et cetera. But yes, certainly, we're open to any discussions around other attributes of our product's value proposition that may be something that we can discuss with the payer community with respect to how we structure, coverage and access.
Okay. So Tony, I guess the easy thing would be to have if you're having an outcomes-based contract, would be to frame it around hospitalizations, right? So if the patient ends up in the hospital, the payer gets more money back in some way. But again, I could also argue the other side, which is the value of this treatment is that you're getting the same outcomes, but you won't have patients gaining weight and having strokes and heart attacks, years later, et cetera. So are you thinking primarily about hospitalizations as the type of outcome that you're looking at?
I think so. That's how I think about it. The other thing I think about too, I think one of I don't know if it was who mentioned it before, but around like we're not really good at identifying people early, and we do have quite a bit of data available, and especially in the commercial market, you have a lot of younger people. So we could work together in one of these arrangements to identify where a patient is more likely to cycle through therapy, and might be more beneficial for. I mean, and I don't want to be brand specific to this drug, but better for a long-acting, injectable or something like that. And my other thing is, like, you can argue you should be doing that anyway, and it's probably fair. But I think those are the things that you could add together to make sure that, in that type of arrangement, that hospitalizations and adherence and access to, getting your drug and seeing the prescriber, seeing your provider, like tie that all in could make a lot of sense here. And let me just caveat by saying, I am not aware of any of those conversations that have gone on, but I mean, that's maybe that's not an outcome as much based therapy, more maybe a value-based therapy kind of contract, but that's kind of what I think about as potentially in this space. Okay, thank you. All right, I want to be brief so we have a good time for the final comments that I'd like to invite you guys to make. I feel like, again, in the usual operating procedure in which people will sometimes think about early insurance coverage, they will look at the criteria that were used for enrollment in the clinical trials, and they will think about whether they should use that as part of the insurance coverage criteria. And one that stood out was that, people were excluded if they had treatment-resistant schizophrenia, if they had persistent symptoms despite 2 trials of other antipsychotic medications. When this gets into the real world, let's assume the FDA approves it for patients with schizophrenia,
I'm assuming I'm asking the clinical experts, I guess, is there any real reason that those patients with treatment-resistant schizophrenia shouldn't be considered valid, eligible participant? I'm not participants, but eligible for this kind of treatment? Is there any reason you would hesitate to use it in them just because they weren't part of the clinical trials?
The reason why it shouldn't be used is because those patients should have a trial of clozapine, which is underutilized. But the reason why it will be used, some of the same reasons why clozapine is underutilized. Clinicians may not fully understand its efficacy. Patients and families are put off by the weekly blood draw and all the metabolic side effects. So I think we'll be seeing it get used with drug refractory patients, just my opinion.
Okay. Bernard, anything different on that?
No, I agree. No.
Okay. Another last question about coverage is that there's a part of the coverage criteria that every insurance company writes about who gets to prescribe it. Any doctor or only specialists with certain training in certain areas. So you heard from David Rind, our chief medical officer, who said it's hard to find adequate psychiatric support to take over the primary care of these patients. And so he's prescribing these antipsychotics. Should this new drug, at least when it's brand new, should it be open to prescription by all providers or only to psychiatric specialists, given its side effect profile, et cetera, et cetera? Steve or Vinod, what do you guys think?
I mean, we have a shortage of psychiatrists, so I would never advocate to restrict access in that way, as long as they are trained and able to treat these patients and are willing to assess their response. I would not see a reason to restrict them from prescribing.
Okay. Steve, do you feel any differently?
No, I agree.
Okay. Marina, the chances that payers will let primary care doctors prescribe this out of the gate?
Well, I think so. So my assumption is, at least initially, that the majority of the prescribing for KarXT will be through psychiatrists. Just, because it's a new product, I think maybe some primary care physicians may feel uneasy, especially if someone is a little newer into their diagnosis and has only, tried one product. But when we look at national payers' current clinical criteria for branded antipsychotics, there typically isn't a specialist stipulation in the criteria. So I expect KarXT will be managed in the same way. And I should say, there's usually not a specialist stipulation for adults. And the other thing I'll say is, if a payer is asking for clinical documentation of a schizophrenia diagnosis, so not just like checking the box, a provider has to send in clinical notes, chart notes, those will likely come from a psychiatrist, I would imagine, like that official schizophrenia diagnosis. So if a payer has a concern around a patient having the appropriate specialist provided diagnosis, I think that kind of takes care of that concern. But bottom line, I don't think there will be a specialist stipulation on KarXT criteria.
Thank you. That's actually a really good point, that if they want to make sure that the right expertise is involved at some level, they can do that through the diagnostic criteria, not just through a restriction on who can prescribe it and who can't. Okay, great. Before we go to final comments, we've covered a lot of territory, but I haven't had a chance to ask you guys at all about future research or the way that research is done as it comes through the FDA and then enters practice. We probably don't have time for really a very deep kind of conversation about that. But I'd love to open the floor to anybody who has a specific idea for here's the type of research that we need most around KarXT and this whole area, or the one thing that you'd really like to change the most about the way that the FDA has been running its approach to adequate evidence for new treatments. So I might turn to our clinical experts first, because you guys do research. What would you guys say is the biggest unmet need right now for the research on KarXT and treatments like KarXT?
Can I respond to the more general question?
Yes, you can. Absolutely.
I know this has been made in print many times before, but I would love a system that gets new drugs to market faster, but once it does get to market, is allowed in a more curated way within the context of studies rather than unrestricted use by prescribers. So some combination of lowering the bar to get it out and then requiring what we would today call post-marketing studies to find comparative effectiveness and place in treatment, because I think the current approach releases medicines that have only beaten placebo, and then they get used somewhat indiscriminately. And we don't understand whether they would be good first in line, second, third, adjunctive. And it takes many, many years before the comparative studies are done. And that's just a lost opportunity. But it also exposes lots of patients to unnecessary delay and risk. So yeah, that would be my hope.
And I might cherry pick and say that that is a perfect role potentially for the Patient-Centered Outcomes Research Institute, or PCORI, which has a fistful of money to do research and could apply it to that kind of question. Anybody
Except
else?
they're bizarrely not allowed to measure cost, but I'll leave.
Well, that we do not have time to comment on that, unfortunately, believe me. But what else? Anything else you guys are patient experts as well? Anything you guys think would be really critical to try to capture as a policy recommendation for the future research needs here? Arun?
We talked about like the PANS as the endpoint a little earlier. I just think that anything that is focused on, like you said, kind of like patient-centered outcomes, allowing patients to really define what matters to them. I know, for example, with like negative symptoms, like there are kind of like different ways of describing them, and they go kind of under detected, as do cognitive symptoms very frequently, to really be able to like build out these endpoints for clinical trials from a patient or lived experience centered perspective is, I think, could make a huge difference in the quality of the sort of research we do.
Good perspective. Marina?
Sure. So I have one, I think it would be really important to understand the impact of KarXT on younger patients. So even, 16 and above, I think that the adolescent patients with schizophrenia are sometimes overlooked, and they have to wait until they reach the age of 18 to get to a different therapy that potentially will work for them. So I think understanding the effectiveness of KarXT in a younger patient population, and again, younger than the clinical trials as well, so still adults. And then I also think it would be really important to understand the clinical significance of KarXT therapy, so as opposed to just the statistical significance on PANS or CGIS. So really understanding, the long-term impacts on cardiometabolic symptoms, hospitalizations, days lost from work or school, ability to maintain employment. And I mean, that's true of any antipsychotic. I would love to have those data just so we can really understand kind of the medical cost offset and just, the kind of the totality of what these therapies mean to these patients.
Well said. Thank you. Okay, that's great. I think I will, because I want to make sure we leave time for your final comments, and then we'll shift to the final comments from the CEPAC members themselves. But I really want to thank you for the policy roundtable that you guys were just contributing to. That kind of conversation to help everybody in the public hear these kinds of issues as they play out, even before the FDA approves a drug. I certainly think it's very, very healthy. And I just want to appreciate your participating and the insightful thinking and kind of creative ideas that you were able to help us with. So what we'd like to do towards the end is invite you to have your final statement. We do ask, and I think this was telegraphed to you before, we ask you to make it one sentence with a strategically placed semicolon. We'll allow that one. And it can be anything. It can be the theme you've said 100 times already, but you want to leave it ringing in people's ears. Or it can be the one thing that wasn't talked about today that you really are afraid that we'll all forget about. And or it can be something where you can turn to someone here at the table or who's not at the table and say, please do this to get the world right for people living with schizophrenia in the context of new treatments like KarXT. So as you're thinking about all that, I'm going to give the patients the last word. And Kristen, I'm going to ask you to go first. And it will give me the opportunity. It will also give me the opportunity to jump the gun. But if you were there at the very beginning of our meeting today, Sarah Emond, ICER's new president, pointed out that what happens the day that the FDA approves a new treatment like KarXT is a justifiable sense of celebration. And that celebration is on multiple levels. But it also represents an appreciation for the science and investment and risk and work that patients and families have taken in the clinical trials, and that companies obviously take in bringing a new treatment to market. So no, you're not approved by the FDA yet, and no, we don't know what your price is yet, but I want to celebrate the possibility certainly that patients will have a new treatment option, and that's very, very important. So congratulations in advance, perhaps. And now, what would you like us to hear from you as your final statement?
Well, you kind of stole my thunder, but I just want to say that individuals living with schizophrenia have been limited to one class of medication essentially for decades. So we should continue to encourage innovation in the development of novel therapies and work collaboratively to provide safe and effective treatment options for and optimize access to patients.
You practiced that sentence, I could tell. That was very, very
Maybe a
good.
little.
Very good. Tony, what can happen to make the world a good place? Go ahead.
Yeah, so I just introduction by saying that I believe that payers are extremely supportive of novel mechanisms in this category and are focused on adherence to drive down costs. And my hope is, I think as everyone on this panel, is that we can layer around support services, more providers and centers of excellence to set these patients up to succeed, to be adherent on therapies that work for them.
Great. Thank you very much. Marina.
Sure. So thank you. So I think I'll end by saying that it's my hope that KarXT is ushering in an era of innovation and in the treatment of schizophrenia. There's a huge unmet need when it comes to a differentiation of treatment options in this population. And I also hope that the approval of KarXT is a catalyst for provider and payer education pertaining to schizophrenia and just helps to shine a light and grow understanding around this disease state.
Great. Thank you. And thank you again for being part of the roundtable. This is your first one, right? A+. Well done. Clinical experts. Yes. Let's go with Vinod first, please.
I'm going to try to compress it to one sentence with a semicolon.
Okay.
How about capitated payments across defined populations that pay for outcomes that cannot be gained, like reduced homelessness, reduced criminal justice involvement, relapse, rehospitalization, and vocational and educational outcomes that will hopefully incentivize the deployment of evidence-based treatments, both pharmacologic and psychosocial.
You went from thinking about something that would cost less than $10 million to that. That's impressive. That's thinking big. I appreciate that. And well said. Thank you. Stephen.
So as Dr. Srihari focused on the general, I'll focus on the specific. Here it comes. As a clinician, I'm really excited by the prospect of having a novel mechanism of action for treatment of schizophrenia. But as a clinical scientist, there's currently no conclusive evidence to suggest that KarXT should be priced above the average price of currently available antipsychotic drugs. Thanks.
Got it. Thank you very much. And now we're going to come to our patient representatives in no particular order. Let me start with Arun.
Sure. So our community is it's desperate for treatment options because of the sheer level of our unmet needs. So the innovation behind KarXT and similar medications targeting muscarinic receptors offers us immense hope. And I want to end by emphasizing our belief in the necessity for systemic reforms to care among those influenced by ICER's evaluations and insurance coverage to just ensure that our community has comprehensive access to all possible treatment options. Thank you.
Thank you very much, very much. Mark, please have a capstone for us.
I really echo what Arun just said, and I hope my comments have given you a fuller sense of how desperately needed new, effective medicines and treatment protocols. In some cases, just doing what we know works and actively doing what we know works are needed. That this is just an incredibly devastating illness for both those suffering directly and their caregivers, and really the broader community. And just that, as is not good enough, that something has to be done here and really applied in a serious way.
Thank you very much. And thank you again for what came through in your earlier statements is obviously the decades of the love and support you've given your son and the work that you do to help others. It's incredibly admirable. And I want to salute and thank you for all of that. And thank you again for being part of a fabulous policy roundtable. If you have to go, obviously understand, but I hope you can stay around and listen to the CEPAC members as they go around. They often have reflections on what you've had to say, and I'll come back for a very short final word. So let me hand it over to Jason to do the to the comments of the CEPAC.
Thank you. Thank you so much. It was for a great policy roundtable. And so I'm just going to go through my colleagues. We have sort of a similar process where people can say one sentence with some of the same caveats that Steve had articulated earlier. So I'm just going to go in the order of my screen, as long as your camera's on, to make sure that I know who's here. So let me start with Jean Ryer.
Oh, thank you. So that was the best policy roundtable ever. Thank you all. And that doesn't count as my sentence. I have been sitting here the whole time thinking about the people I know and the families affected by schizophrenia. And there are, you know, 2 handfuls in my life. And I suspect you have the same. And if you don't, it's because they've become invisible to you. And for many reasons, one of which could be death. The other is that they're just invisible. They're in some system that you don't see anymore. So Mark and Arun, thank you. I feel like this is an exciting next step. I hope you all will take it as clinicians and as payers. It wouldn't be a CEPAC meeting that I didn't say something about the price. And I am concerned particularly about the price and its impact both on families and on state Medicaid programs, who are probably picking up about 50% of the tab for this. And by the way, also know how to do those kinds of wraparound effective services that several of you have alluded to. So Kristen, think about the price hard, please, and get it as low as you can. Thank you.
Thank you. Dr. Martha Gold has her video back up and working, so I'll go to her. You're on mute though.
Thank you very much for a really elucidating discussion on all fronts, both from the science and from the real world experience. I guess what I'm left with is the thought that, not that I want the price for the drug to be high, but you know, when I think about the social costs of living with this illness, if one could make some real gains, it would do so much to not only improve the quality of people's lives, but it would be economically a wonderful thing for this country, for this world.
Yeah, absolutely. Thank you. Dr. Brian O'Sullivan. I think you're on mute. Brian.
For a minute there, I couldn't unmute. I'm sorry. Just to keep it short and sweet, I'm thrilled by the new mechanism of action for a drug in a disease state that needs innovation. So that's great. I wish we had longer term information. I've been uncomfortable voting today because we need more long-term data. So I'd ask Karuna to be able to share all that with us when they have it. And again, applaud the patients and parents for educating me about the difficulty of this disease. This has been a wonderful meeting. Thank you.
Thank you. Dr. Lavelle, Tara.
Thank you. And yeah, I just wanted to say thanks to everyone. I really think this is one of the best meetings I've been to, and particularly thanks to the Arun and Mark for your comments, and just very clear the impact that this has on patients and families. And like we talked about before, I think this is just a really important next step and next treatment option. But I do think the next important step is to really have pragmatic studies that really study the real world use of this, and to really look at the health and economic outcomes that come from the real world use of this. So thank you, everyone.
Thank you. Rebecca Kirsch.
Thank you. Mark, you and your wife, who, if she's not there, please thank her from all of us as well. I know you're a team. And Arun, I'm so struck, and Stephanie made this point a couple of times, the disparity in research investment, which is part of why we're all here struggling with this vote. The evidence isn't there because the research investment hasn't been made. And I think that it certainly put fire in my belly around the importance of mental health parity in terms of coverage, access, but also the research investment part. There's no good reason why we don't have better evidence here other than NIH hasn't prioritized it. So I think it's on all of us to lift that up as a priority.
Yeah, no, it's such an important point. Don Kreis.
Thank you. For me, I think the most poignant moment of the day happened while Ms. Guardiola was describing her experience of schizophrenia and the delusion that she was suffering around the Immaculate Conception. Because as she was saying that, I noticed that Mark offered up a smile and even a little bit of a laugh, which to me testified to the kind of wisdom and insight and good humor and love that he and his family bring to this, arising out of the just unbelievable struggle that he and his loved ones have had to endure and what they've had to summon. And so therefore, I'm sorry we didn't spend the day arguing about a $300,000 a year or $1 million a year medication that would be so much more closer to a cure. I hope we get to have that CEPAC meeting. And I hope that Mark and his family get to come to that meeting too.
Yeah, we all do. Dr. Steve Kogut.
I was hoping you wouldn't pick me to follow up on those eloquent words by Donald. I don't know if I can, other than to say thanks to the patients and patient representatives who really brought to life what's in the report, but really hard to make visible without your compelling stories. Semicolon. Let's hope this jumpstarts an era of drug development for, a period that's been really stagnant. So hopes for that.
Dr. Rab Asseltine.
Thank you all. In all my years on CEPAC, we've dealt with some very tough conditions that really have been challenging for patients and caregivers. But I don't think we've seen one that's quite as pervasive and challenging. And so on the one hand, I am always saddened to hear those stories, but on the other, encouraged to see some new breakthroughs that could potentially help.
Thank you. Dr. Stephanie Nichols.
I want to echo pretty much everyone. This has been an excellent meeting, and thank you to everyone, but particularly thank you to our patients and our family, our people with lived experience, patients and those who are caregivers of patients and people with lived experience. What I want to use for my time here is to share a potential solution to something that has come up several times today, and that is the unmet need for additional training of psychiatrists, but also primary care providers that are going to be prescribing antipsychotics. So there is a solution. There are over 1,000 of us that are board certified psychiatric pharmacists, BCPPs. We have an organization, the American Association of Psychiatric Pharmacists, and I actually have a proposal that I'm happy to share with anyone that talks about using us as a consult service for providers. So one thing I would offer as a possibility is there may be a cost-effective mechanism where perhaps payers would want to work out some kind of agreement with a board certified psychiatric pharmacist, which might help prescribing all sorts of antipsychotics for patients with schizophrenia and ensure adequate monitoring and safety as well. Thank you.
Thank you. Dr. Jason Schwartz.
Thanks, Jason. Thanks to the ICER team and especially to our patient experts for their powerful witness and insights they shared. I've been on the CEPAC for about 5 years now, and I can't think of a time where there's been a bigger gap between my votes and the impression that my votes might suggest a certain pessimism about this drug and its performance and its effects, and how I really feel because of the sort of challenges around evidence. So I just want to underscore that we have lots of reasons for good optimism about this potential drug as potentially even transformative for the kinds of benefits it can bring to patients as a new tool, new type of tool that we need to learn more about, and we absolutely need to better understand its effects over the long term. But I hope that will come should this product be approved in a way that provides as few barriers to access to providers and patients as possible. So I'm very hopeful, even though there's still much to be learned. Thanks so much.
Thank you. And I believe I'm a little mixed up on the video screen, but I think the only person left is Megan Golden. So if anyone else is, I haven't, let me know that before she stops speaking. Go ahead.
Thank you. I agree this was an excellent meeting, and especially the policy roundtable. I learned a lot and appreciate everybody's contributions. I think the timing was challenging and felt a little bit like a catch-22, in that we wanted to review it now because decisions are going to be made in terms of pricing and coverage, and yet the evidence isn't there, so we couldn't really, so the vote was overwhelmingly negative. I was also struck by the fact that there are a lot of effective evidence-based interventions that exist that are underutilized. And so what I would hope in the future is that there's a future review that's looking at new evidence of KarXT, but also maybe evidence of some of these other evidence-based practices that could drive pricing. And maybe some of those practices should be actually priced a bit higher. Thank you.
Thank you. I think one negative thing about serving as the chair I've realized is that I have to speak after all my sort of eloquent colleagues. So I guess the first thing I wanted to say is that I thank my colleagues on the CEPAC for being so compassionate and thoughtful and sort of really committed to making healthcare in America better. Most importantly, I am so grateful. It's been a wonderful day for me simply to see and bear witness to the extraordinary compassion from the caregivers that have joined us, the patients' families, the courage of the individuals living with schizophrenia. I mean, think about how hard it is to come to have the disorder, to come to our session, to sort of share your stories. I am honored to be a part of that, and I'm humbled to be a part of that. And I think the thing that I take away from this, and I say this as a cardiologist who has no particular expertise at all in schizophrenia, is that I'm struck over and over by how care delivery systems have failed individuals living with schizophrenia. Mental health providers aren't available. We're talking about primary care prescribing a lot of these medicines, but primary care is breaking, and we're just asking them to do something else. We don't really have a great mechanism. And in the end, a lot of these individuals end up in jail. I mean, this is really, we are totally not doing justice to these individuals living with schizophrenia. And it even makes me reflect, as someone who's a total non-expert, about things in my life. I think about, it gives me memories of medical school when I was the one after midnight to 6 a.m. in the emergency department, fishing out people with potential acute abdomens. A lot of these people had schizophrenia, and because they didn't have adequate outpatient resources, they ended up in the ED being evaluated for abdominal pain. It was really the wrong setting for them to receive care. So how can we make these kinds of systems of care better to give justice to these people? When you hear stories about a father on our Zoom here saying that his son has been put in jail and sexually assaulted, I mean, can you imagine as a parent anything harder? I can't. And so when are we going to get to a system that delivers care, whatever therapies may be available in the future, that delivers them to these individuals, attentive to their needs, that often they don't perceive that they have a disorder and may not like the way the medications make them feel, and doesn't really fit cleanly in the sort of consentability framework that we use in medicine. So I don't think we've done justice to these people, for these people, and I do think that we can do better in the future. And I'm grateful to all of you for an amazing session of really thoughtful dialogue.
Jason, thank you. That was lovely on all levels. I just have a little bit to add. Partly it's just to thank you, Jason, for chairing this great meeting. You did a fantastic job. CEPAC, again, you always bring your heads, your hearts, your thoughts, your experience, and it's a very rich conversation that I really do think helps benefit the future that we can bring for patients with schizophrenia. Thank you again, also obviously to the Policy Roundtable and the people who also came to give public comments. So my general comment that I'd like to add at the end is how often we have these meetings around what I could term a train wreck, where there's been, essentially inadequate research done leading to the approval of a drug that costs way too much, that will usually lead to further access restrictions, overall increase in healthcare premiums. And we kind of get the innovation right in some ways, but we kind of mess up the entire process such that it doesn't really get us to a better overall healthcare system for patients. This doesn't feel like that. We have the opportunity, and it's a little bit early, but that's part of it. We're before some of these things have happened, but this is how it could or is supposed to work. There's a condition that has tremendous unmet need, driving hopefully, a lot of research and innovation. And we have a company that has developed a new mechanism of action that, may not be a home run, but it's going to likely offer an important new option for patients and clinicians. And it's going to come into the market at an expensive price compared to generic treatment options. That's the way it's supposed to work, because it'll be expensive for a while and then it'll have a generic price later on. And all of that has to happen in a sense in which, yes, we feel critically engaged with the idea that schizophrenia needs new treatment options, good ones, but we also have to acknowledge that the price is not irrelevant, that the price is linked to access, that there's a price that would be way too high. And so this is part of that broader social contract that we talk about, but it's not just on manufacturers' heads to come and think about what a reasonable or good price would be. That has to be twinned with what good insurance access looks like. So if we got, a price, and again, even with the estimates that we have, it's not far, if you will, from what you could consider a fair value-based price. If that only leads to insurers bottling it up in the back room so that you can't get to it, that's going to not create the right kind of paradigm for the future, and it's certainly not going to help patients in the short term. So that combination of getting a fair price and an affordable price with good access, boy, if there was an opportunity to get it right for people and their families living with schizophrenia would be fantastic. So no train wreck, but the opportunity for a real win-win, one that could set the agenda for a lot of the future. So that being said, there are storm clouds, above. The company was bought for $14 billion, largely on the basis of this one drug. Somebody's going to want to make $14 billion back from their investment. That's maybe the right way to go, because it sends a signal that, wow, there's a lot of money to be made if you develop a positive signal in schizophrenia. On the other hand, it could lead to that same kind of worry that the only way that the system works is to charge extremely high prices as part of that bargain. So I'm still hopeful that we can get to the win-win, that this will be a great example of a future, not just for people with schizophrenia, but for other conditions. And I think some of the ideas and aspirations, hopes that people brought to the Policy Roundtable will be an important part of getting there. So thank you again, CEPAC, and everybody else who participated today. The last slide we have just says that we will be putting out a final version of the report, and usually it's just a few weeks. That will have hopefully a robust description of the conversation we had in and around the votes, and some Policy Roundtable generated policy recommendations. So thank you again. Look forward to putting that out into the public domain, and hope you all have a good rest of your afternoon and a good weekend. Thank you, everybody.
Thank you.